In Part 1, we learnt about procedure, lead placement, waves and calculation of squares. I welcome you all to Part 2 of this series on ECG analysis and interpretation. Let us begin with the cardiac conduction pathway. In the right auricle, a group of cells called the SA node are self-excitable. So they generate the impulse, which then reaches the left atrium. This results in simultaneous contraction of both the atria and generation of P wave. Next, the impulse passes to the atrioventricular node, which is located in the inferior wall of right auricle. It acts as a gatekeeper for the impulses received from SA node. Ordinarily, the AV node should allow the conduction of impulses, but there is a momentary pause to allow ventricular filling after atrial contraction. Time taken for an impulse to travel from SA node to bundle of His through the AV node is nothing but the PQ interval. From AV node, impulse passes through the bundle of His, a specialized group of cells located in the septum, which then divides into the right and left bundle branches. This results in septal depolarization and the beginning of ventricular contraction. Finally, Purkinje fibers carry impulses to myocardium of the right and left ventricles. So, AV node to bundle of His until Purkinje fibers result in ventricular contraction. And this is documented as the QRS complex in our ECG report. This ends the conduction pathway. Let us look at the 4 physiological properties of myocardial cells. These are automaticity, excitability, conductivity, and contractility. Automaticity is the ability to initiate an impulse, and this property is exclusive to the cells of SA node. Excitability is the ability to respond, and all the cells of heart exhibit this property. Conductivity stands for ability to transmit impulses. AV node, bundle of His and the Purkinje fibers express this trait. Lastly, contractility, it refers to the pumping action of myocardial cells. Do you recognize this from Part 1? 10 leads provide 12 views of the heart. You must be wondering, how would 10 leads give a reading of 12? Let me decode this for you. In a 12-lead ECG, 10 electrodes are used. 4 of them on the limbs and 6 on the chest wall. In the limb leads, the one on the right leg is an earth electrode, it is neutral. It is also called a dummy electrode. It does not record any activity, so actually we have only 3 working limb electrodes. So, completely forget about the right limb electrode. 3 unipolar and 3 bipolar leads are obtained from these 3 working electrodes. This helps in recording electrical activity of the heart from 6 different angles. The 3 bipolar leads are lead 1, lead 2, and lead 3. Let us understand them via Einthoven's triangle. Lead 1 is between right arm and left arm. Lead 2 between right arm and left leg. And lead 3 is between left arm and left leg. These are bipolar because they measure potential difference between 2 electrodes. Now, how to assign the electrical charges? These are our 3 bipolar leads. Remember that the right arm will always be negative, while the left leg would always be positive. So automatically, the one forming a part of lead 1 on the left arm will be positive, and the one in association with lead 3 would be negative. You can see the same in this image here. Hence, lead 1 is potential of left arm minus the potential of right arm. Lead 2 is left foot minus the right arm. And lead 3 is left leg minus the left arm. The same 3 limb leads used initially also give 3 more unipolar leads. These are AVR, AVL and AVF. The prefix A in these unipolar leads stand for augmented, hence these are also called augmented leads. AVR, try to remember it as R for right arm, AVL, L for the left arm, and AVF, F for foot, of course the left one, because right foot is a dummy. This point is called as Wilson's central terminal, and it is assumed to be 0, it is the sum of leads 1, 2 and 3. Since the other end measures 0, these leads measure the potential of just one pole, hence they are named unipolar. If we look again, we get to know that 3 limb leads gave us 3 bipolar leads called 1, 2 and 3, and 3 unipolar leads, namely AVR, AVL and AVF. We already had 6 unipolar chest leads. So see, in this manner you get 12 readings with just 9 working electrodes. But why do we need 12 different readings? How does that help? The most common pathology for which an ECG is used is ischemic heart disease. So if there's an MI, You can locate the exact spot of infarct with the help of 12 leads. If we look at the precordial leads in a horizontal plane, it would be like this. Note that a myocardial infarction can occur mostly in the left ventricle. As you can see, V3 and V4 are anterior to the left ventricle, so abnormality in V3 and V4 would depict an MI of the anterior wall. Similarly, V5 and V6 are laterally positioned with respect to left ventricle, hence abnormal V5 or V6 lead indicates a lateral wall MI. This is the interventricular septum. It is clearly evident that septum is recorded by V1 and V2, so they would signal an MI of the lateral wall. Just a while ago, we discussed about our limb leads, and those 6 leads look like this if we observe from the front. Lead 3, AVF and 2 demarcate the inferior surface. These 3 leads would indicate an inferior wall MI. Abnormal lead 1 and AVL would also specify MI of the lateral wall, while AVR holds no significance as such. If we club this information together, we get to know that 1, AVL, V5, and V6 are lateral leads. 2, 3 and AVF are inferior ones. V1 and V2 are septal leads, while V3 and V4 represent the anterior wall of heart. Let us wind part 2 by understanding the calculation of heart rate. If you recall, we learned about calculations regarding squares in part 1. We discussed that every small square is 0.04 seconds, so one large square which has 5 of such small squares would be 0.04 into 5, which is 0.2 seconds. 5 large squares would hence be 1 second. So in 60 seconds, or say 1 minute, how many large squares? That's right, 60 multiplied by 5, 300 large squares. Also 60 seconds could be coined as 1500 small squares. So the formula for heart rate is 300 divided by RR interval in large squares. Or similarly, 1500 divided by RR interval in small squares. Now the first step in calculating heart rate is to check the rhythm, whether it is regular or irregular. A regular rhythm is when the RR intervals are equal and consistent throughout the ECG. If the rhythm is regular, you can go ahead and directly use this formula. Let us take an example of a regular rhythm. You can see that the number of large boxes between 2 R waves is 4. So 300 divided by 4, and it's 75 beats per minute. You can also verify the second method. 4 large squares means 20 small boxes. 1500 divided by 20, and again 75 is the heart rate. For irregular rhythms, heart rate is number of QRS complex in 30 large squares multiplied by 10. Because ECG paper runs at a speed of 25 mm per second, which is 5 large squares per second. So in 6 seconds 30 large boxes, and for 60 seconds, 30 into 10. Hence the formula. Number of QRS complex in 30 large boxes into 10. In this case, number of QRS complex in 30 large boxes is 12. So heart rate would be 12 into 10, 120 beats per minute. So now you can easily know if your patient has a tachy or bradycardia. A normal heart rate ranges from 60 to 100 beats per minute. Resting heart rate of fewer than 60 beats per minute qualifies as bradycardia. Consider a heart rate of over 100 beats per minute to be tachycardia. If you like this video, kindly subscribe to Dr. D Codes for more. And do not forget to share.